on dysphagia. We all will be knowing certain things about dysphagia, and everybody knows, so it would be just an input in your knowledge. So I would request Aarti ma'am, Sanjani, Sneha is not there. Anaga, Mansi.
Dr. Balkar, please join us.
Dr. Balkar.
This way you go?
Yeah. So
Come
shall
this
I?
So come this side.
IAPEN Pune chapter. He is the director of Angel Clinic Diabetes Care, Head Department of Medicine and Diabetes in Ruby Hall. He is a senior consultant in diabetes medicine in Jahangir Hospital. He is fellow of the American College of Endocrinology, fellow of American College of Physicians. He is an honorary secretary governing council of National RSSDI, member editorial board, BMJ Open Diabetes Research and Care Journal. He is actively involved as principal investigator in landmark international research trials and a faculty at various international and national and international meetings. Please may I call upon.
Good evening everybody, and thank you for this honor. First of all, when Richard told me I should lead the IAPEN Pune chapter, I was kind of wondering what a clinician is going to do in a nutritionist crowd. But today I see a lot of meaning to that, because we are no more compartmentalized to think that nutritionists and the clinicians work separately. Because I think it's a more of interdependency that we tend to have, and I'm sure going forwards, nutrition is going to be a very important part of how we are going to take care of various illnesses. I can speak from the diabetes perspective because that's where my core competency is. And we are trying to now see that how we can bring in the front, nutrition advice. Right now we are in the process of actually framing the national RSSDI guidelines on diabetes-specific nutrition. And we have started our meetings, and this is in association with the NIN, National Institute of Nutrition. So they and we are combined hands, and we are framing the India guidelines for diabetes-specific nutrition, which will be followed by, of course, obesity-specific nutrition guidelines. But I'm sure that various societies across the country would also be very keenly looking at how they can partner with the nutritionists and the clinicians coming together and framing some way, some kind of a thought process, how we should integrate this in our patient care practices. I think IAPN has been doing a great job, and I have been sort of talking to Richa about this, of the various activities, and my predecessors have done a great job in bringing the body up to a certain level. What we need to do is, of course, take it to the next level from where we are. And one of the most important things that we need to see is all our members get involved in the activities that we do from the IAPN, because it is not something that is specific only to the core group, the executive committee, or everybody of you are equally part of the IAPN, and everybody should be responsible to see that we contribute to the functioning of the IAPN, be it in leadership roles or be it as carrying out the various activities of the IAPN. Please feel free to reach out to any one of us from the executive committee, me or Richa or any of the executive committee members. If you have an idea, we will be happy to support that idea in whatever way we can and see to it that each idea brings to a conclusion something that we can do from the Pune chapter. We need to bring up our memberships obviously because numbers really tell the story and numbers bring support, be it at any level. So we need to see that each one of us can reach out to our fellow people and see how many of them we can convert them and ask them to be part of the IAPEN. Also, I'm sure going forward we'll have a lot of activities that will be planned out and we will be looking forward to all of you being part of these activities to see that, how we can implement it. A lot of education probably will have to come from a reverse way, the nutritionists educating the clinicians. And that's where a little gap is. And we want to see that how we can bridge the gap between the clinicians and the nutritionists. And let's hope that with me being on board, not only at Pune level but at the national level, we'll be able to make a lot of headway in this area and come up with something more meaningful. We've got a lot of nutrition that is now infiltrating from the technology, from various nutraceutical companies that are coming in. So it is very important that we make a judicious use of all these new modalities that we have on our board and how we can make the best use of this for patient care practices. So we shouldn't be sort of one size fits all kind of attitude and take it ahead. But core principles never change and we need to ensure that the core principles continue to be on the topmost, and these are just add-on sort of help that we can take to make these our advices more important. So I'll just stop here and welcome our guests, Dr. Bhargat and Dr. Shiv Shankar, and I would keenly like to listen to both of you on what you would like to deliberate today, and welcome all of you to this first meeting of the IAPEN under our leadership. And let's have a great year ahead with all of us, contributing something. Thank you very much.
Shiv Shankar to felicitate our members. May I call upon Dr. Bhushan Valgat, who is currently associated with Sahyadri Group of Hospitals, Pune as a consultant oncosurgeon. He has gained a profound amount of hands-on experience in operating cancer patients over the patients of 7 years. Furthermore, he has attained higher laparoscopy training at World Laparoscopy Hospital, Pune. Sanjay sir, please. Sorry, Bhushan Valgat sir, please.
In front of so many cancers, GI cancers, or usually in general about cancers, how to treat. For the audience is usually general practitioners or consultants. Today the audience is nutritionists, dietitians. So the topic given to me was dysphagia in cancer. I am Dr. Bhushan Valgat. I work at Sahyadri. let's start the topic today. So, the ability to swallow is something that many of us take for granted. It's a boon for us given by God until we experience this symptom called as dysphagia. This is a very dysfunctional thing a patient has to go through. Yeah, it causes a lot of morbidity in the patient. Even after treatment, the patient is not always very happy. It basically means having trouble swallowing. Please note, you already might know that there's a difference between dysphagia and odynophagia. Odynophagia basically means there's pain during swallowing, and dysphagia means he's not able to swallow. So odynophagia could lead to dysphagia, but it's not the reverse way always. What is the physiology of swallowing? Swallowing usually has 4 phases. It's the oral swallowing phase, the oral chewing phase, the oral transit phase, the pharyngeal phase, and the esophageal phase. So oral chewing phase, basically the saliva comes in, the enzymes digest the food, whatever is possible in the mouth, and then it goes into the oral transit phase where the tongue touches the palate and the soft palate, and the food bolus is pushed behind into the pharynx. During this phase, the swallowing is still going on. But during the pharyngeal phase, when the food is already in the pharynx, the epiglottis comes and closes the laryngeal inlet, and the food goes from the pharynx into the esophagus. During this phase, the soft palate prevents the food from going back into the nasopharynx. And in the third phase, which is the esophageal phase, again this inhalation and expiration goes on. The upper esophageal sphincter closes, and the food, due to peristalsis of the esophagus, goes down bit by bit. So if you understand the physiology of swallowing, you will understand dysphagia. So how do we subjectively assess swallowing? There are 2 methods. One is the swallowing efficiency and one is the swallowing safety. So what do we mean by swallowing efficiency is how quickly and effortlessly you are able to swallow. That is subjectively assessment of dysphagia. Inefficient swallowing results that the food accumulates in the oral cavity or in the pharynx, and that is a main symptom of dysphagia. It might take a long time for the food bolus to go down, and the patient usually complains that some food is stuck in my oral cavity or in my throat. The second way to assess dysphagia subjectively, this is not the objective ways. Objective ways will be discussed ahead by the other eminent speakers. The second way to subjectively assess is swallowing safety. By swallowing safety, we mean the food bolus or any particles of the food should not go into the airway or the laryngeal inlet and cause aspiration, because aspiration causes pneumonia, and that so efficiency and safety are the 2 ways to assess dysphagia. Now, grades of dysphagia. This was about the degrees of dysphagia. The grades of dysphagia can be classified as per the NCCN or Takia classification, or there are other classifications also. I would not be going to the details of each, but what we follow as oncologists is the NCCN guidelines, which say there are 4 grades of dysphagia, which divided into swallowing, able to swallow solid in piece whole, swallow in pieces, then swallow only liquids, and unable to swallow anything. Now coming to what causes dysphagia. So dysphagia could be due to, because we are talking only about cancer or oncology, I am focusing only on the causes which are related to cancer. So it could be a tumor compression, that is anatomic dysphagia. It could be dysmotility due to the tumor, that is neurologic dysphagia, or it could be iatrogenic, that is you have treated the symptoms of cancer, but due to the surgery or radiation, it has caused more dysphagia, or it has not relieved the dysphagia due to cancer. It has relieved the dysphagia due to cancer, but it has caused the flap-related dysphagia or swallowing-related dysphagia. So these are the causes. In detail, let us see. The anatomic type of dysphagia, compression, could occur due to luminal, extraluminal, or intraluminal. By this I mean, luminal means the tumor is protruding into the lumen and causing the food bolus to not enter into the GI tract easily. The common causes are the large tumor at the base of tongue, epiglottic tumors, or the spiriform fossa tumors. Extraluminal tumors are the tumors which occur outside the lumen of the GIT, like in the pharynx we can have large lymph nodes in the neck which compress on the pharynx. We can have large deep parotid tumors which can compress on the pharynx. These are extraluminal tumors which can cause dysphagia. And the third one is luminal. Luminal dysphagias are very less common, because usually luminal means there is a thickening in the esophagus which causes dysphagia. But usually luminal converts into intraluminal because there is a protrusion of the tumor into the lumen. The other dysphagia is due to dysmotility due to the tumor. So cancer, not only by mechanical obstruction but due to dysmotility, can also cause dysphagia. This is rare, only found in 2 to 3% of the cases due to tumor that causes dysmotility. Mainly it is due to mechanical causes. And the third, like I discussed, iatrogenic. So if there is a tumor in the tongue, we do a hemiglossectomy, we put a flap. If there is a tumor in the pharynx, we do a laryngopharyngectomy and we put a PMC or a radial flap, any free flap. That flap might be a bit bulky, or that flap is not neurogenic. That means it does not contain the nerves, like the nerves which are supplying the normal mucosa or the normal muscles of the pharynx, the sphincters, that are not present in the artificial flap which is taken from the hand or the leg. So that could cause a iatrogenic dysphagia in a form of mechanical obstruction of the flap, or because the flap is not able to move, that might also cause a neurogenic dysphagia due to surgery. The other cause of iatrogenic dysphagia in cancers is radiation. Radiation induces inflammation in any tissue. If we give a radiation of more than 60 to 70 gray in tumors of pharynx, the limit is 60 gray. If we go more than that because the tumor is large or the tumor is not responding, that causes a lot of inflammation, and inflammation, as we all know, leads to mucositis, and mucositis leads to strictures, and that causes iatrogenic dysphagia. So in short, these are the causes of dysphagia due to cancer. Like you can see in this image, these are a few images of my patients, few are taken from the internet. The various causes of dysphagia can be seen on, these are the CT scan images. How to differentiate a CT and MRI is very simple. The bone is bright on a CT scan and the bone is not bright, it is usually black or light grey on a MRI. Usually it's black. So these all are images of a CT scan. You can see the mandible very easily here highlighted in each and every image. You can see the spine very easily highlighted here. So this is a CT scan. On CT, the right side is usually on the left and left is on the right. Why we see the CT? Because the CT film is seen from the leg side, from the lower side of the patient. So this is on the left side of the patient. This is a large tumor in the buccal cavity of the patient which is coming intraluminal. This is the tongue, or this is the hard palate area which is pushed. Usually the tongue is pushed towards the opposite side and causes dysphagia. In this image of a CT scan, you can see this is the pharynx. And this tumor is intraluminal tumor at the base of the tongue, and this is causing a pharyngeal dysphagia. In this image, you can easily see there is a tumor which is outside the pharynx. This is the pharynx. In this, you can see the tumor is intraluminal. This circle has to be a black circle completely. It has come inside. Here the circle is almost black. It is shortened due to the tumor compression from outside. So this is an example of extraluminal pharyngeal oropharyngeal dysphagia, and it is causing a compression from outside. The fourth image you can see is a tumor at the piriform fossa. So as you can see, this is white image which is just below the mandible is the thyroid or the cricoid cartilage. This is the thyroid cartilage you can see, and this is the tracheal inlet here, and this is the pharyngeal inlet. You can see a tumor in the piriform fossa on the right side which is causing a dysphagia due to a pharyngeal tumor. So this was an oral cavity tumor. This was a oropharynx intraluminal, this was a oropharynx extraluminal, and this is the pharyngeal tumor at the piriform fossa. Below two images are of a CT scan of a thorax, which you can see this is the trachea, very clear cut, it is circular. You can see this esophagus just behind it, and you can see the thickening of the esophagus. Normally, like this, esophagus is very thin, trachea is so thin, esophagus is almost that much thin. There is a thickening, so this is a tumor in the mid-esophagus. Similarly, this is coming to the lower thorax, that is the junction of thorax and abdomen. So this is the liver. You can see a lot of liver mets here. These small circles in the liver are liver metastasis. The tumor is at the lower end of esophagus. You can see the black colored dot, which is the small lumen of the esophagus due to the compression of the tumor at the G junction. So these are the various levels at which dysphagia can occur. It could be oral, it could be oropharyngeal, or it could be esophageal. Now, what investigations we have to do when when a patient comes to us complaining of food is being stuck in the oral cavity or dysphagia? So to rule out anatomic dysphagia, first of all, the most common cause is anatomic. So we rule out anatomic dysphagia. Contrast enhanced CT scan should be done in each and every patient. Please remember, do not do a HRCT if any of your relatives unfortunately has a symptom of dysphagia and you go ahead and you think that CT scan should be done because somewhere I have heard or somebody has done. Please remember, a contrast always should have been done for each and every tumor in the body. Usually a contrast should be there. So contrast CT starting from a skull base up to the thorax has to be done for a complaint of dysphagia. After that, because this is a non-invasive investigation, non-invasive means we are not entering into the body of the patient. So always a non-invasive investigation has to be done first, followed by an invasive investigation. So the second investigation we can see is the upper GI endoscopy, and that is the invasive investigation. So after a contrast CT, if you find there is some tumor, we have to see it and get a biopsy of that tumor. So upper GI endoscopy is done, in which we see the oral cavity, the oropharynx, the esophagus, the stomach, the duodenum first part and up to the second part. All this is covered in the upper GI endoscopy. The third investigation, a barium swallow, usually nowadays is not used for a mechanical obstruction. Previously it was used because good quality CT scans were not available. Nowadays barium swallow is reserved for video fluoroscopy, or as we have some swallowing therapists here, they see the swallowing mechanism or the swallowing physiology using a video fluoroscopy using a barium swallow. That is a very common indication for barium swallow. For mechanical, we do not use barium swallows now. The other cause of neurologic or iatrogenic dysphagia, that is the surgically or radiation induced or neurologic induced, is the dynamic swallowing study, which right now I talked about. This dynamic swallowing study is here done using a barium swallow, in which we give a radio opaque food bolus to the patient in various sizes, various consistencies the patient is told to swallow, and a video fluoroscopy is just like an X-ray image done in a dynamic form. That is, dynamic means it's not a simple static X-ray, it is continuously done. So we see the bolus moving from the oral cavity up to the lower end of esophagus, and we see exactly where the tumor is, the bolus is not able to go down. This is not for anatomy, but where the muscles of the GIT are not working. Now a better investigation than a dynamic swallowing study has come up, that is the FEES. Please do not confuse this FEES with FESS. FESS is an investigation done by ENT surgeons to note the nasal cavity and the paranasal sinuses. This is FEES, it's a fiber optic endoscopic evaluation. So it's simple, the terminology says it's all. It's an endoscope which is kept at the level of soft palate, and we see the movement at the oropharynx. The disadvantage of FEES is that because it is only used to see the oropharynx, we cannot see the oral transit phase of the patient, and there is usually head neck cancer patients complain of oral dysphagia rather than oropharyngeal and esophageal dysphagia. FEES is reserved for patients in which oropharyngeal and esophageal dysphagia is there. And the third investigation, not usually for tumors but done for dysphagias of other causes other than tumors, is esophageal manometry. Causes like achalasia cardia can be diagnosed with esophageal manometry. Now coming to the last part of my presentation, I was told that you have been given 20 minutes, so I was a bit quick. So the management is, we usually do not treat cancer, we have to treat a patient as a whole, as we all know. So not only a surgeon or not only a radiation oncologist is required, we need nutritionists, we need physiotherapists, we need swallowing therapists, we need prosthodontics to treat a head neck cancer or a oropharyngeal cancer patient. So one by one, let us see what is the management of dysphagia. Dysphagia management could be divided into three forms for simplification purposes. It could be curative, it could be palliative, and it could be supportive. Curative, like we have oral cancer patients, we have oropharyngeal, we have esophageal cancer patients, in which the surgeries which we do, I have highlighted in next slides, each of them, that surgery is curative. Radiation could be used for curation or palliation alone. For palliation alone, endoscopic stenting or other forms also I have discussed in future slides. And the supportive care is given by the most important people, the nutritionist and the prosthodontics people, swallowing therapists. So one by one, let us see in short what each of these means. In surgical, like I have highlighted, if the cancer is in the oral cavity, it's from the buccal mucosa, or it's from the tongue, or it's from the palate, which is causing a luminal obstruction, we do a commando surgery, we do a palatectomy, or we do a glossectomy. Usually, these are the common surgeries. For oropharynx, usually the treatment is by radiation, and it's not by surgery. But if at all we have to go ahead, nowadays robots have come ahead, and robotic surgeries have made oropharyngeal surgeries easy. So in that case, oropharyngeal resection could be curative for dysphagia of oropharynx. Laryngopharyngectomy is done for tumors of pharynx. I guess you are aware of the anatomy. Pharynx, the hypopharynx is very close to the larynx. And if there is a tumor in the hypopharynx, the larynx also has to be removed because the anterior wall of hypopharynx is the posterior wall of larynx. And the blood supply of both are common. Hence, while removing the hypopharyngeal tumors, like the piriform fossa, we also have to remove the larynx. And that causes a permanent tracheostomy in the neck, which is a very morbid surgery. So if the patient is in the early stage, we usually prefer radiation. If it is an advanced stage, we prefer surgery for laryngopharyngeal tumors. And the last surgery is esophagectomy. So dysphagia is esophageal, that is the tumor is in the mid or lower esophagus, surgery is advised. If the tumor is in the upper esophagus, surgery is not advised because for any esophageal tumors we require a 10 centimeter margin. The length of esophagus is 25 centimeter total. So if the tumor is in the upper esophagus, we are not able to get an upper margin, and so we prefer a radiation over surgery in upper esophagus. For lower and mid esophagus, surgery is the treatment of choice. The other curative option is radiation. So radiation could be definitive, adjuvant and palliative. What do these three terms mean? So if the patient is coming in an early stage, or if the patient is not fit for surgery, we tell the patient to get radiation alone. In that case, the dose of radiation is very high. That is called as definitive radiation. That is the only treatment that patient is going to take. That is definitive radiation. Adjuvant radiation means the treatment which is taken after surgery. So when we do a esophagectomy or we do a oral cavity cancer patient, and the tumor is very high grade or the tumor is invasive, we tell the patient to take radiation after surgery. That is called as adjuvant radiation. And palliative radiation means you cannot do anything for the patient but just supportive care. In that case, if there are spinal metastasis, especially the spine causes cord compression, and radiation is a very good option for a patient who has spine mets. And 8 grade dose is given for such patients. Now coming to the second option, that is the palliative option, that is endoscopic stenting. We have a lot of gastroenterologists doing nowadays a lot of therapeutic procedures other than only diagnostic, one of which is endoscopic stenting. The stent is a small stent, like we have already heard of angioplasty. The stent goes in, it expands. That is a kind of similar stenting is done in endoscopy. It goes through the tumor and it expands. But the problem with these stents, these are metal stents. They can cause tumor perforation in a long stage. If the patient we know is very palliative, is not going to live for long, then SEMS stents can be put because the risk of tumor perforation is high in the long term. Other risk is stent migration, that the stent can go up or below and again can cause tumor obstruction. Nutrition, very important thing for any patient of dysphagia. I will not go into detail because a lot of eminent speakers are going to speak on it. There are two types, enteral and parenteral, and a combined nutrition. The supportive care which comes up for patients who have been operated or given radiation is post-op management or a post-RT management. So speech swallowing therapists are very important part of this, because the main complaint even after surgery is not able to swallow, like I discussed, due to anatomic obstruction of the flap or inability to move the flap. And the second is the prosthodontics. They do a lot of palatal prosthesis, lot of teeth guide which help the patient to chew and swallow properly. This was all about my presentation. Thank you so much for patiently listening to me.
Richa. Now we have already seen and heard what dysphagia is. Now we will go upon for the management of dysphagia, the assessment of dysphagia basically. May I call upon Megha Kapoor, who is currently working as clinical dietitian at Tata Memorial Hospital, Mumbai, completed MSc Specialized Dietetics in 2019 and 20, presented paper titled Study of Child Feeding Practices in Severe Acute Malnourished Children, and received consolation prizes for oral abstract presentation ICNC 2023. Please may I call upon Megha Kapoor.
Myself, Megha Kapoor. I would like to thank Pune chapter and Valleysure for giving me this opportunity. I'll be talking about swallowing assessment and diet frameworks of dysphagia. So first I would be talking about what is swallowing. I think Bhushan sir has explained this very well. It has 3 phases. I'll just reiterate the same concept. So first is the oral phase, wherein the bolus is propagated towards by the tongue into your upper esophagus, pharynx area. Then the second is the pharyngeal phase, which has 2 ways to function. That is, first it propagates it into the pharynx and the upper esophagus, And second, it blocks with the help of the epiglottis, the larynx, so that the food doesn't enter the trachea. Third is the esophageal phase, where the food enters from the pharynx, upper esophagus to esophagus sphincter to the esophagus. So there are impaired swallowing such as coughing, wet gurgling voice. There is a feeling of food getting stuck in the esophagus or in the mouth. There is also pain and difficulty in swallowing. So this is one of the videos of a patient who came to our OPD. So here you can see she is swallowing water, and when she is in a straight position she can swallow it well. But at the same time, when she is swallowing water and she bends down, the water drools out from her mouth. So this is a kind of impaired swallowing which is seen in patients. So dysphagia, as it was discussed earlier as well, it is called as a difficulty or disordered swallowing. So in the pharyngeal phase, it enters the trachea, and this is one kind of pharyngeal dysphagia. Similarly, there is also esophageal dysphagia, wherein the food, by chance of entering into the trachea, it gets stuck in the esophagus because the esophageal peristalsis is not functioning, as you can see in this video as well. So causes of dysphagia, this is being covered, so I won't be talking about this much. So there are two causes mainly classified as oropharyngeal and the esophageal causes of dysphagia. Next, the complications are, first is the aspiration. So aspiration is very commonly caused due to dysphagia, which can lead to pneumonia. Then poor oral hygiene can cause oral infections. Since the patient is non-compliant due to dysphagia, there are chances that patient end up with malnutrition. So since this is my topic, so how to evaluate dysphagia. So before heading on, I would like to tell you the role of speech and swallow therapists. So their role is to perform clinical swallowing and feeding evaluation. They perform instrumental assessment of swallowing function with medical professions. They are good at identifying the normal and abnormal swallowing. They identify the signs of possible and potential disorders for the dysphagia. Also, they help in making the decision about the management of swallowing, feeding and feeding disorders. So firstly, the swallowing screening includes, they ask about the case history, what is the case history of the patient. Second is the assessment of the oral motor structures and their function. So this I'll be covering in my later part. And third, they assess the speech and vocal quality. I'll not be touching upon this topic as we are dietitians, so I'll be focusing on nutrition only. The main thing which they focus upon and which is of our use is they try to assess the coordination of respiration and swallowing for boluses of various sizes and consistency, which help us in planning our diets when the patient has dysphagia. So the non-instrumental swallowing assessment, basically in this, the speech and swallow therapist will give trials to the patient for including consistencies of different boluses of different sizes, and accordingly they assess their evidence of oral control and mastication. There is also, they detect the behavioral signs of symptoms such as throat clearing, or is there any congestion after having the bolus feed. Then also impact on the respiratory function after swallowing. Also they see the changes to the physiological status, also like voice quality and the vital signs. They also help the patient's use of additional, if the patient needs additional equipment for swallowing, like particular types of spoons or drinking cups to swallow certain boluses of different size and consistency. So there are a few examinations I would like to tell which is done in a preliminary level for this by the speech and swallow therapist. They do an oral mechanism examination wherein they evaluate the face, jaw, teeth evaluation is done. They see the tongue evaluation where they detect if there is any unnatural movement like jerking, twitching of the tongue. There is also pharynx evaluation by detecting the color and status of tonsils, whether it's enlarged or normal. Also soft and hard palate evaluation is done, and they observe the nasality, the uvula or the clefting and gag reflex seen in these patients who have dysphagia. There is also functional oral intake scale, wherein these boluses are given when given to these patients. They evaluate the oropharyngeal dysphagia basically. They assess the patient's food swallowing capacity, measure the effectiveness of the patient's oral intake. So FOIS has 7 levels. So I won't get into detail, but they score as like 1 is for aspiration. So this patient would be dependent on an RT tube, and so the patient has to be kept milk by mouth. And 7 is for like regular diet, so there is no restrictions and patient can eat a normal oral diet. There's also one test which is very feasible and very quick and simple assessment, that is the 100 ml swallow test, in which the patient is given sometimes a colored water to swallow, and using this this helps in detecting the aspiration in these patients, and also help to highlight patients who require any instrumental assessment, which I will be talking further. Based on the swallowing test, they also assess by grading these using this Leipzig-Pearson scale, wherein the assessment of the swallowing aspiration function is done as per the grading. So grade 1 is for no aspiration, and grade 3 is like apparent cough increase with the implementation of the bolus feeds. So coming to the non-instrumental assessment, so one is video fluoroscopy. So video fluoroscopy, basically it's conducted by a speech swallow therapist along with a radiologist. It incorporates set of modifications of the bolus sizes and the radiographic focus to facilitate optimum visualization of the oropharyngeal structure and their function during the swallowing. So as you can see, it determines the presence and timing amount of aspiration. So as you can see in this picture as well, so this black line, it indicates that the barium which was diluted with the bolus is lined in the trachea, which shows that there is aspiration. Also, video fluoroscopy can be used as a follow-up method, wherein to see whether the rehabilitative measures can be were useful for the compensatory skills on the bolus transport during the swallowing, which can be assessed using a video fluoroscopy. It also can be assessed using this aspiration penetration aspiration scale. I won't be going in detail, but it tells you a certain kind of scoring. Like first is the material does not enter any airway, and 7th, for example, it passes below the vocal folds and is not ejected from the trachea despite the effort done by the patient who has dysphagia. So this is just a video wherein this is a kind of normal swallowing, the patient who has abnormal swallowing. So as you can see, the food primarily enters the trachea. So this is one of the case examples. So this is an example of a case study done in our hospital. So the patient was underwent total thyroidectomy and undergoing RT right now. He has an NG tube inserted and he is taking sips of water in a chin tuck posture. Chin tuck posture meaning the chin is tucked on the inward side and you pull your head straight. And so when this patient was assessed, it was seen that this functional oral intake examination score was 2. Then he had a higher risk of aspiration. The swallow test was also done in chin tuck posture. It was seen that he had a clinical severe oropharyngeal dysphagia for thin liquids only. So his penetration aspiration scale was 7. So basically, even after a chin tuck posture, he was not able to swallow properly the thin liquids, and so he had a severe pharyngeal dysphagia with severe aspiration. And this particular case patient was advised NG tube for thin liquids, and orally he could take small quantities of soft diet. So the next is fiber optic endoscopic evaluation of swallowing. It's a Fees test. So basically it utilizes a scope, nasopharyngeal laryngoscope, which is taken in simple language to your pharynx region, and then barium is swallowing is given to this patient to actually detect the aspects of the pharyngeal and swallow function. As you can see, The video is little fast actually, but there is some blue color dyed if you can see. So this helps them to detect whether the dye is entering the trachea or no, in simple language. So phase basically helps in examining the structure and function of the larynx and pharynx, also evaluation of the presence and degree of aspiration. It's a method, best means of feeding by to establish which is the better means of feeding for these patients. Is it by mouth or by mouth with dietary restrictions or by tube? Also, presentation of foods and liquids as a swallow is assessed. So based on this test also, in if you know certain kinds of patient like who underwent esophagectomy as well. So in that case, it's also they use this test when they have to shift the patient from the NJ tube feeding to a oral diet as well. Next is manometry. So manometry is usually used to measure pressures generated in your pharynx and the larynx. So basically one thin catheter with pressure sensors is inserted through the nose, pharynx and your esophagus, and various pressures are noted and compared with the normal values. So here one of the case wherein this patient has a normal esophageal peristalsis. So the y-axis is basically the length between the upper and the lower esophageal sphincter, and the time, that is the x-axis for timing for one swallow. So this patient has a normal esophageal peristalsis. But on the other hand, this patient, the esophageal peristalsis is absent and there is no pressure exerted by your lower esophageal sphincter. So they have a low LES pressure. So there are certain classifications and definitions for certain aspects which are covered in manometry, which I will not be going into detail. There are certain other investigations as well. So there is esophagogastroduodenoscopy, wherein which diagnosis of the esophagitis, esophageal strictures and the tumors. Then there is endoscopy of your larynx, that is laryngoscopy, and also barium esophagogram, wherein the esophageal dysphagia and eclasia is detected. So coming to the diet frameworks of dysphagia, so since we spoke about the assessment of swallowing, so once this assessment is done, so we need to go further with the dietary intervention based on the assessment and results assessed by the speech and swallow therapists. So I don't know how many of you are aware of it, but there are certain diet frameworks which have been released by certain organizations, and one of these is International Dysphagia Standardization Initiative, that is also known as IDSI. It's a global standard with terminology and definitions to describe the texture modifications and thickened liquids or their consistency for all types of patients of all ages who have dysphagia. So in this basically they have two diagrams, sorry. So they have a grading for the drinks, like for the liquid. So they have thin, slightly thick, mildly thick, moderately thick, extremely thick gradings for the textures for different foods, and also for food that is easy to chew, soft bite size, minced, moist and pureed and liquidized. So this is one of the protocols is followed for dysphagia patients as well. So there are certain instructions for following these, for making these type of consistency. So one is for liquids is the IDSI flow test. So basically here they put the fluid in the syringe and it has to be flowed for like a particular 10 seconds, and after a point a particular amount of the liquid should be there in your syringe. So this varies based on the consistency, like for 0, 1, 2, 3, 4. So for example, for this is for second, that is mildly thick. So after a point, more than 8 ml should be present in your syringe. Similarly, they have it for solids as well. So for pureed, they will instruct to follow a IDSI spoon tilt test, wherein your sample, whatever you are making, the consistency should be like that it should hold the shape on the spoon and falls off fairly easily. For mints and moist particular, they have defined the sizes to be given to adult and pediatric, like 4 mm for adult and 2 mm for pediatric. It should be soft enough to get squashed easily with fork or spoon, and you don't need any physical pressure to it. Then they also have defined soft and bite-sized, wherein they tell that the food pieces should not be more than 8 mm lump size and should not be bigger than 1.5 centimeter bite. So it should be easily chewable and easily can be blenched with the help of a fork. So this is one of the frameworks, like now if you go home and you will be searching about frameworks, there is one more called as National Dysphagia Diet, but no more it is being used right now because now it has been upgraded to ITZY only. So they have to change their terminologies as per the ITZY diet only. Then there is one by the Japanese, that is the Japanese Dysphagia Diet of 2021. Here they have made their pyramid based from the jelly consistency to their solid foods. So they have classified their dysphagia diet as per mildly thick, moderately thick and extremely thick. But additional to this, certain aspect which they have included is the viscosity. They have mentioned the particular viscosity of your feed which is to be there when you are preparing this feeds. Also LST, that is the line spread test, and syringe residual amount test like you have seen in the ITZY. Also for the solid diet, they have defined based on the jelly consistency. So for example, your 0J should be a homogeneous jelly consistency form, while your 2-1 should be a pureed or a paste which is made from rice and without grains. So this is kind of types of diet they have defined. But these kind of diets are quite complicated if we see on an Indian household basis. So very difficult to be practically performed in the Indian household kitchens. So that is the reason we should actually come up with certain aspects which can be easier for us for such a varied culture and diversity of our country. So for that reason, one of the consensus statement released by the IAPEN India was a modified texture dysphagia diet, wherein they talk about the bolus food consistency modification is an effective strategy for improving nutritional and hydration status. So not only we should focus on the consistency but also the nutritional aspect when we are giving any dysphagia diet to any patient. So far which we have seen ITZY and Japanese, they are more focused on the consistency and not on the nutrition is what we felt. So that is the reason one of the diet released by IAPEN is the modified texture dysphagia diet for Indians. So it has six aspects, and based on that there are certain recipes advised for them as well. And according to this, it can help you in making diet plans for the patient based on the assessment done by the speech and swallow therapist. And this would be covered by the next speaker, so I won't be really talking about this in detail. Thank you.
May I call upon Aarti Valleysure to felicitate Megha. Shiv Shankar is the Vice President of IAPEN India chapter. He is a Vice President of Asian Nutrition Society as well, ex-chairperson.
Thank you for that introduction, and good evening one and all. Congratulations to Pune chapter for relaunch, and I can see a full house over here. It's really inspiring, because I used to hear that Pune people are reluctant to attend the CAP, and you people have proved that that was wrong. And I can take a lot of messages from this event and really give good associations with you all. And in fact, if you have any kind of a request, any particular kind of a topic to be addressed, or any kind of a particular CNEs or workshop are needed, the committee is quite vibrant when I spoke to them, and they are very receptive in getting your request for that one. And we assure you that whatever is required for you all, educational, any kind of educational events, we will be there for you. So today we started with dysphagia because at many places dysphagia being discussed, and the way it is being managed, a lot of advances are taking place. There is a slight change in the order over here after Megha's actually, which I was supposed to speak about the intervention, and mine was the futuristic kind of a dysphagia management. which is maybe a little bit of things which are not practical as of today when I'm talking to you, but maybe in the next couple of years, many things are going to come up what I'm going to speak about it. For that, the things you may ask that, the things which are not practical today, why to discuss about it? So unless until you discuss about it and ask to the companies that we need these kind of products or these kind of interventions, the companies will not be ready to get those technologies over here. So we are quite early in making the request to the companies to get the kind of a product what the dysphagia management really needs. So this is the reason why I started talking about the advancement, like the futuristic of dysphagia management. Why it is so important to speak about dysphagia? If you all really have some kind of an idea regarding the life expectancy at the time of your independence, it was something around 47 years or 48 years. Now it's increased to 70, 75 years. As the population grows, the incidence of dysphagia is also going to grow. Megha did mention about the Japanese dysphagia modified textures recommendations as well. In fact, Japanese have more than 5 to 6 recommendations, even though it's such a small country. But you all know that is the only country where the people are living beyond 90 years and 100 years, almost in the entire population. In fact, they have the highest population of the geriatric population compared to even India doesn't have, even though we are such a hugely populated country. But the numbers in Japan are really, really big. After that Japan, then comes the Korea and other the Asian Pacific. Because of the kind of the lifestyle they lead. You don't see a Japanese obese patient or person. How many of you really have come across any Japanese person who is obese as well? So difficult to get a picture of them. So the kind of lifestyle they lead and the way they have that dietary influence from the childhood till the geriatric populations are very impressive. So this is where we need to really bring out our changes as well. In fact, we are moving towards a Western adaptation of the diet. We already adapted and we are moving towards. So, and we are seeing the results as well. So very soon we are going to have these issues of dysphagia management for our own populations, and this is where we actually should start asking for the things what we really need in the near future. We hear a lot of things regarding the dysphagia. We heard the previous two speakers talk about what is dysphagia actually about it. So the physiological and pathophysiological presentations were very impressive by the two presenters. But let us see what the patients describe the dysphagia. That is where you are going to, when the patient is sitting across, you are not going to open a book and see what kind of a dysphagia the patient is talking about. But when a patient describes to you what the difficulty the patient is undergoing, your perception changes over there. Now what I should be really recommending to this patient? Is it just that